Yay. All right. Good morning, everyone. It's a tough act to follow. It's inconsiderate of Sean to look this good. I'm reeling, but I will recover. So for those of you who don't know me, my name's Sam Evans. This is my CPL lecture. I'm going to time myself here as we all get out. The case at the beginning of this lecture was adapted from a section in Schwartz's Emergency Radiology. As a disclaimer, this is a pretty huge topic I'm covering, and it would take a lot of hours to cover it effectively. So I'm just hoping to give everyone, a few pieces of review, a few tidbits that'll help you take care of patients later. Great. Let's start with a case presentation. So I'll give everyone a chance to review the case. This is a 34-year-old female brought in by ambulance for 3 hours of dyspnea associated with some dull substernal chest pain. She's saying, "I can't breathe." Her vitals are as shown. Just a couple other pertinent points on history. She's an occasional smoker and she takes oral contraceptive pills. On physical exam, the vitals are here again. She's in moderate distress. She's overweight. She's diaphoretic, tachycardic, and tachypnic. So what would be the next study you'd want to see just based off this initial presentation? Kyle. What do you want to do?
What do I want to do?
Yeah. What do you want to get quick?
What do I want to get quick? We got the vitals.
Yeah, we got it. We got this.
I'm thinking of things like I'm worried about, or I think it might kill it. I'm thinking I don't want to jump to the CTA right away.
Yeah. So what's a test that we can get in like 2 seconds? Love it. Love it. An EKG. Yeah, we'll get one of those. So who can, we got a time issue. Who can tell me what rhythm we're in? Just very briefly, shout it out. Yeah, our sinus tach, right? We're a little tachycardic here, less than 3 big boxes. Can anybody tell me what they see abnormal on this ECG? You shout it out. Yeah.
Systematical, right? Rhythm rate.
I didn't budget for this much silence, guys. We'll give everyone a few more seconds. Anything abnormal that you see. Maybe try focusing on the precordial leads, taking a look at V1, V2, V3. Sure, maybe. So what I'm seeing here is I'm seeing some T-wave inversions in V1, V2, V3, and also some T-wave inversions in lead 3 as well, which generally indicates, as we learned earlier, actually sort of a right ventricular strain pattern. The chest x-ray is normal, labs notable for a dimer of 850 and slight acidosis on the VBG. So the patient, based on all of this, was hurried to CTPA, where we got our diagnosis of acute pulmonary embolism, which is the subject of my talk today. So what we'll cover just in brief, prevalence and risk factors of PE, a little pathophys, some common presentations of PE, which can be very variable, workup, a little bit of management and disposition as well. Okay. So PE can be a tough diagnosis, but getting it right really represents a huge mortality benefit to our patients. So you can really minimize your misses here by just making sure you're doing a good physical exam, thoroughly assessing any pertinent risk factors in the history, and then understanding the various ways that PE can present. So there are a lot of risk factors for the development of PE on this slide. I've just listed a few that are considered major risk factors, so a pretty high relative risk of at least 5. So post-op states, immobility, which also goes with post-op states, but also we have to think of our geriatric bedbound patients, malignancy, especially advanced metastatic cancers, pregnancy. There's various obstetric risk factors, late pregnancy, C-section, as well as the 6 weeks after pregnancy, you're still at quite elevated risk. And then as well as a history of VTE. The statistic is something like 33% of patients who have a history of DVT or PE will have a repeat event in the next 10 years. So common presentations, can I have someone just throw out a percentage? How often do you think patients with diagnosed PE present with dyspnea? 60? Okay. Yeah, it's like 73. How about pleuritic chest pain? Yeah, 44. Dang, Ryan's killing it. I'm going to show you a few more of these for the sake of time. So tachypnea, a sign that we consider so ubiquitous like tachypnea, it's really only about half the time. Who wants to guess fever? It's not 0%. It's not 30%. It's about 3%. So a rare sign like fever is really important to understand, not so much to rule in a PE, but so you don't prematurely exclude a PE from your differential just because, oh, my patient has a 103 fever, they have to be infected. That has to be what's going on, right? It might not be. Next, I want to touch on some clinical rules. So of course, we all know the Wells criteria, but it's important to make sure that we use Wells appropriately. So Wells is fundamentally a risk stratification tool that tries to estimate pre-test probability. So this isn't a rule that should be applied to every patient, right? Every patient with chest pain or shortness of breath, right? You have to have some good clinical suspicion of pulmonary embolism before you apply the tool. There are in the 3-tiered version of the Wells criteria. Low risk, you generally want to try to perk them out, or if you have some nagging suspicion, you can get a dimer. For intermediate risk, you can either go right to CTPA or dimer. And then for your high risk patients, which is a score of, I believe, 6 or above, you usually want to be moving right to CTPA and then sometimes even treating empirically if you feel strongly. Okay, quick note on the age-adjusted D-dimer. So you want to make sure you're using the age adjustment. The adjustment is +10 for every year past the age of 50. So a 60-year-old is going to have a new cutoff of 600, not 500. I believe King's already adjusts their dimers, but as someone who just finished a UHB, we do not. So if you've got a 70-year-old patient and they have a dimer of 600, it's negative. So you're not sacrificing any sensitivity by adjusting. A few more clinical rules. I'll just briefly mention the existence of the years algorithm, which inputs these 4 clinical measures plus a dimer and then guides you as to whether or not you should get a CTPA. The nice thing about years is that you can use it in pregnant patients, which you really shouldn't be doing in Wells. Pregnant patients were sort of excluded from the validation of the Wells criteria. Here's the PERC rule. Notice that there's a lot of overlap with Wells. I've highlighted really what are the only criteria not present on Wells in some form. What's important to understand about PERC is that it's a unidirectional rule, right? So if somebody perks out, you're done, right? You don't need to do anything more. But if somebody doesn't perk out, that doesn't mean your hand is forced into getting a dimer, right? If a 55-year-old who otherwise perks out and you've got a low suspicion for PE, you don't need to necessarily get a dimer on him. I'll briefly touch on the classifications of PE just because it's important for risk stratification. Massive PE is generally going to be your classic saddle embolists. These patients are going to be really sick, in varying stages of obstructive shock. So realizing what's going on and treating is really vital. Submassive PE patients will generally be quite symptomatic, but they'll be at least, for the moment, stable, right? So what we're looking for here are really signs of right ventricular dysfunction, either on EKG or on point of care ultrasound, as well as, signs of end organ damage, elevated troponin, elevated lactate, things like that. Subsegmental or non-massive PEs are smaller. They're not going to be, crazy obstructive. They're generally not going to be killing patients, but, it's still important to catch these and to diagnose and dispo them effectively. So there's a great MCRIT page on all of this. Risk stratification, this is basically sick versus not sick, but I do think it's helpful to sort of understand the logic behind some of the intuitions that we make in the emergency department when we're looking at patients. If a patient presents with syncope, pre-syncope, that's generally bad. It shows essentially a lack of physiologic reserve, and they're going to be at increased risk for decompensation. Symptom duration is important. So 5 days of symptoms, generally going to be a little bit more stable than 2 hours of symptoms, right? All else being equal. Diaphoresis is also really concerning, right? This is also intuitive, but it really reflects the idea that the patient is being kept stable by their own endogenous secretion of epinephrine, and they could be headed for a crash. My last pearl is that, there are SBP criteria that generally indicate massive PE, but I don't find it that helpful to review. We all know an SBP of 65 is bad, right? So I would just say, make sure we keep an eye on relative hypotension, right? If we have a patient, we have a history on, they come in at 160 systolic every week, on the nose, and then suddenly they're at 100 systolic, right? That represents a huge departure from their baseline, even though it's technically above our criteria of 90. This is pulled straight from MCRIT. It's really great. I'm not going to go into every single bullet point here, but this is really helpful for building a mental framework. Generally, the questions you're asking in order are, okay, is this a low risk PE? If not, is this a massive PE? And if not, by process of elimination, I'm considering it a submassive PE. How concerned am I? where do I dispo this patient and what therapies need to be initiated? And there's evidence-based guidelines for all of this, all of these questions. So having a framework like this is really helpful. I'm showing the PESI score here just to highlight that not all PE patients, necessarily need admission. And there are guidelines we can use to justify those decisions if we do choose to dispo home. A negative PESI means that they have about 1% mortality in the next, I forget how long the time period is. And then an additional like 1.5% chance of recurrent thrombus. A single positive marker on PESI increases their risk of death about 9-fold. So if anyone pops positive on any of these, it's probably going to be an admission. And again, this is more of a unidirectional tool. So just because someone's negative on all of these doesn't mean that you have to send them home. I mean, obviously, you know, you have to look at the overall clinical picture. So the 3 pillars of management are going to be supportive care, anticoagulation, and thrombolysis. Supportive care generally means maintaining their oxygen saturation, providing hemodynamic support. You know, when we're providing hemodynamic support to these patients, generally fluids is sort of a mainstay for most presentations, definitely not for this, right? Because they're already obstructed. You know, volume is not the issue. So we want to diagnose promptly and avoid pumping them full of fluids. Instead, what we want to do is support them with pressors. And also, you know, we actually talked about this a little earlier in the day in some of our cases, but, you know, there's drugs that will dilate the pulmonary arteries, right? Pulmonary vasodilators that can really help forward flow. In terms of anticoagulation, not all patients need to be started on AC, but many do. The choice of AC is really complicated. It's sort of beyond the scope of my little spiel, but generally it seems like patients that are getting sent home will get put on something like a DOAC, and then stable patients that aren't getting thrombolysis that are going to come into the hospital are going to get put on like a Lovenox, like a low molecular weight heparin. For hemodynamically stable patients, thrombolysis generally isn't indicated. For unstable patients, both mechanical thrombectomy and TPA are going to be considerations. The evidence for decisions related to when to use TPA, what dose to use, right? Are you going with the full dose of 100, 50? I saw an article that even advocated in certain niche situations for like a quarter dose. It's all still being hashed out in the literature. It's a little bit controversial. It's going to depend a lot on like, you know, your practice and what your hospital does, things like that. Some places do systemic TPA, some do catheter-directed therapy, just squirt the TPA right on the clot. Again, this is all very like institution dependent, and there are a lot of trials ongoing to try to better assess this question. So my teaching points, just in summary, correctly diagnosing and managing PE really represents a huge benefit to the morbidity and mortality for our patients. The presentation of PE is really variable, so care should be taken not to prematurely exclude it from a differential. Wells, PERC, Years, PESI, these are all really good clinical tools, but they shouldn't be substituted for clinical judgment. And in fact, a lot of these tools incorporate clinical judgment into the scoring system, just to show the importance of that. Most stable patients need supportive care and some form of anticoagulation, and crashing patients are likely to benefit from thrombolysis, whether it's mechanical thrombectomy, TPA, et cetera. And then having just a mental framework for working up and risk stratifying PE patients will really allow you to treat and dispo them more effectively. These are my references, and thank you very much.